All right. Welcome everybody to our January Echo series. This one focuses on immunology. If you are new to participating in Echo, we do begin each of our sessions with the same basic structure. We start off with brief introductions. For today, we will have you go ahead and do that in the chat because we have such a large attendance, which is exciting. We then will have a presentation by one of our guest speakers, or actually two of our guest speakers today, and then we'll have an interactive case-based discussion. Then we do a brief session wrap up. So introductions, in the interest of time, as I said before, we ask you to just introduce yourself in the chat. Please tell us your name, your profession, and what clinic or organization you are here with. This helps us keep track of where our reach is getting to. As for me, my name is Andy Hazley. I'm the coalition manager of Mountains of Hope, which is our state cancer coalition, and I will be facilitating today's meeting. My co-facilitator is Mary Ellen Kahn, and I'll let her introduce herself to you.
Hi, good afternoon, everyone. Thank you for being here today. I'm Mary Ellen Kahn. I am with Cancer Prevention and Control at the WVU Cancer Institute, and I also serve as the program director for our state's comprehensive cancer control program, which helps to support the Mountains of Hope Cancer Coalition.
And our two guest presenters today are Dr. Bustamante and Adrienne Duckworth. Adrienne, would you mind introducing yourself briefly to our attendees?
Yeah, I can do that. My name is Adrienne Duckworth. I'm a nurse practitioner in the Cancer Center at Morgantown. I work primarily with lung and head and neck cancer patients. I also direct our survivorship program for Mary Bab Randolph Cancer Center, and I serve as the regional lead APP for our HEMONC section.
Thank you so much, Adrienne, for being with us today. And Dr. Bustamante, could you please give our attendees a little bit of information about you?
Sure. So I am Jean Bustamante. I'm one of the HEMONC doctors at the Cancer Center. I focus on thoracic oncology. I mostly see, lung cancer, mesotheliomas. I also do a little bit of benign hematology, and I run the molecular tumor board as well. And I also use a lot of immunotherapy, so that's part of why I'm here.
And thanks again to both of you for sharing your lunch hour with us today. We really appreciate having you as our presenters. So before we begin, just a few quick reminders and some housekeeping. If you feel comfortable doing so, or if you're in an area where you can, because we know a lot of you are in clinical spaces, we do encourage you to turn on your cameras. It just helps make the session more engaging for our presenters. Please make sure you mute your microphones during the session. We absolutely want to hear from you. So you can unmute or raise your hand to speak for questions and discussion. Because this is a large group today, if we can try to remember to use the raise hand feature, that will probably help. I'm horrible at remembering to use the raise hand feature, so if you don't, it's no worries, but I think it'll help us streamline our conversation a little bit, and then hopefully we won't talk over each other. So if you're not sure where that is, it's in the under your reactions. There's you can click that, and there's a I disappeared for a minute. That was very strange. Yay, technology. Anyway, so in your reactions, there's a raise hand button. You just click that, and then Mary Ellen or myself, look, she's demonstrating. We read each other's minds. That'll go up, and then we'll recognize people to ask questions. Just because this is a large group, we want to make sure everybody has a chance to contribute. The session is recorded. It'll be archived, and excerpts may be used for educational purposes. And we do also post these on our Echo YouTube page, and we'll provide that link for you in the follow-up. When you participate, of course, you indicate consent to the recording and archiving and use for these purposes. And please remember, when you're sharing, do not disclose any personal information that can identify patients presented in Echo. Finally, just our business end of things. This series is approved through the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The WVU Office of CME designates this live activity for a maximum of 1 AMA PRA Category 1 credit. This continuing education activity has been provided by the West Virginia University School of Nursing for 1.2 contact hours. If you did not pre-register, or if you have not done the registration for CE before, as I mentioned, that link will be in the chat. You just click that link, fill that out, and then we process your continuing education credits. And without further delay, I will turn it over to Dr. Bustamante and Adrienne Duckworth, who will begin with the didactic portion of our echo. Give me just a second. I'll get our presentation up here. 1 second, click that first, that'll help. Right, that's not it. Okay, there we go. Okay. I am going to turn my camera off so that it doesn't bog down my screen sharing for Dr. Bustamante and Adrienne Duckworth and other presentations. So Dr. Bustamante, the floor is yours.
Thank you. So thank you for inviting me and Adrienne. Basically, we're gonna just start with a few definitions of what immunotherapy is and what subtypes we have in at least in the cancer realm. Thank you. So immunotherapy basically consists on, or at least the one type of immunotherapy we're talking about today, it consists on monoclonal antibodies that have been developed so that we can use the immune system to treat cancer. What happens is that we have several immune checkpoint inhibitors or immune checkpoints that basically are like spots throughout different immunological pathways that are natural and physiological for the immune system to regulate itself. That's why they're called immune checkpoints. So if these immune checkpoints are hijacked by cancer cells, then we can have problems that the immune system cannot detect cancer. So we have different type of immunotherapies. The most common type is PD-1 and PD-L1 inhibitors. And we also have other subtypes that we use commonly, like anti-CTLA-4. And there are some drugs that are not necessarily monoclonal antibodies, and they're more like biologicals, which are CAR T cells, which is the patient's own immune cells that are engineered genetically and used against certain lymphomas and lymphoblastic leukemias, and that is also a form of immunotherapy. And then we have anti-LAG3, which is also an immune checkpoint inhibitor that is combined with PD-1 blockage in melanoma and was recently approved. So the drugs that you're going to see most often, maybe in a patient that you follow in the primary care clinic or that you see in the emergency room, is going to be pembrolizumab or Keytruda, which is an anti-PD-1. You'll often see nivolumab as well, cemiplimab, dostarlimab. Those are all anti-PD-1 drugs that are used in different type of cancers like melanomas, lung cancers. You can see sometimes in some gastrointestinal cancers. Anti-PD-L1, which are also involved in the same pathway of PD-1, PD-L1 axis. We have durvalumab, atezolizumab, that again, they can be used in lung cancer, in hepatocellular carcinomas, in bladder cancer. And then we have anti-CTLA-4, which is ipilimumab. The commercial name is Yervoy, and tremelimumab, which was recently approved in a lung cancer regimen. But you rarely are going to see that second one, but ipilimumab you'll definitely see in melanoma and lung cancer patients and some other gastrointestinal diseases. Next. So this is pretty much how it works, the mechanism of action of this checkpoint. So you can see the blue cell, it's a cartoon of a T cell, and the tumor cell is a yellow cell. And the T cell is pretty much asleep when it's interacting, when it's binding the PD-1 protein with the PD-L1 in the cancer cell. And that is why we're always talking about what is the PD-L1 percentage in the tumor cell, and depending on that, we kind of decide if we give chemo or chemo plus immuno or immunotherapy combinations. So our different drugs like anti-PD-1 or anti-PD-L1 inhibitors are represented in the right side of the slide. You can see the cartoon, the red head arrows or arrowheads, and you can see that they are blocking that interaction between PD-1 and PD-L1. And when you block that, you allow the immune cell, the T cell, to wake up. And once it wakes up, it can recognize the tumor cell and can kill the tumor cell. Now, the problem here is that there are several tissues that also use this mechanism so that the immune system doesn't attack them. And these are like basically tissues that are normal tissues that are not cancer tissue or tumor cells, and that's when we can start seeing immune therapy related side effects. So virtually any organ can get inflamed. Next. So these are the most common side effects. Is 10 to 30% of the patients that will have fatigue, joint pain, thyroid dysfunction, and skin rash. And we're going to elaborate a little bit more on thyroid dysfunction and skin rash. Joint pain is, you have to just tease out if this is just an old arthritis or is this like an inflammatory process. And fatigue is kind of difficult to assess as well because patients are usually fatigued from cancer, from other therapies like radiation. If there's a chemo component to it, that will make them tired as well. So that's very wishy-washy, to be honest, but sometimes the fatigue is so profound that you may need to stop the treatment. Next. These are the serious side effects. You usually see it between 1% and 3%, sometimes even less than 1%. So when I'm talking to patients about this, I usually say that virtually any organ can get inflamed. And when we see serious side effects are grade 3 and 4, that will usually require stopping the drug, maybe doing steroids, and sometimes hospital stay. So you can see they go from pneumonitis, colitis, hepatitis, nephritis. So anything can get inflamed. A lot of the glands including the pancreas, you can see diabetes, the new onset diabetes. You can even see exocrine pancreatic insufficiency. You can see eye inflammation, uveitis. So, we kind of have to be looking for all of these potential side effects and have a real clear communication with the patients on what to expect and let us know what's going on so that we can catch this early and doesn't evolve to a grade 3 or 4. Next. So pneumonitis is one that I particularly see. It's more often than I would like, but the reason is because I also see lung cancer and there's a lot of radiation involved. So when there's radiation, then you also run into the confusion. Is this from radiation? Is this from immunotherapy? What's going on? Is there a COPD exacerbation on top of it? Because patients are tend to have a diagnosis also of COPD if they were long term smokers. The differential, like I said, radiation, pneumonia, there are others like sudden shortness of breath. You can see pulmonary embolism, and the diagnosis is a combination of clinical diagnosis with imaging, CT chest x-rays, and you also have to rule out the differential. So the management pretty much depends on what is the etiology, of course, if it's radiation induced or if it's immunotherapy induced. And if you're pretty sure if it is immunotherapy, of course, you have to hold immunotherapy. You should, well, and that's going to be done by the oncologist, of course. But if you have a patient that is presenting to your office and they're on immunotherapy, the ideal thing is to make sure you rule out infections and you start treating for all of that and discuss with the oncologist because we need to see them quickly and we need to start some form of either prednisone or IV type of steroids like Solumedrol if this is serious, and it has to happen really quick. We usually like to rule out infections, and if the patient ends up in the hospital, we typically consult pulmonary. They may or may not get a bronch done, and they probably will also get on top of these antibiotics, because it's really hard to decide in some instances what is it that's going on. And generally after 48 to 72 hours of being on steroids, if patients do not respond, you would probably want to add something like IVIG, and in some cases also mycophenolate as more immunosuppressions. And when you reach these degrees of immunotherapy related pneumonitis, you will probably have to hold immunotherapy indefinitely and try to go to a different type of treatment. But whenever a patient is in immunotherapy, you have to make sure that you just don't let this patient go untreated like a COPD exacerbation or like an infection. You need to make sure you are not missing a pneumonitis. You usually will see in the CAT scan, and in the X-ray, a diffuse bilateral infiltrate with ground glass opacities. And it's very important, because if this evolves to a degree that patients need to be hospitalized, maybe intubated or not, and they didn't receive steroids soon enough, this can be lethal, which is basically a grade 5 pneumonitis. Next. Colitis is another one that I usually worried about a lot, because it will usually present like a diarrhea, maybe from a gastroenteritis type of situation, but patients usually have 4 more bowel movements that are watery above their baseline. So let's say they do 2 a day normally, and now they have 6, and they are watery, and they also have cramps. So differential diagnoses are chemo-induced if there's chemo added to the regimen, and also infectious diarrhea. So typically also diagnosis involves CT abdomen pelvis, rule out infections, and clinical clinical clues. And the management is very similar. We hold immunotherapy, we consult GI and oncology. We try to have patients get loperamide or difenoxylate atropine pills and manage that way. But anytime they have also abdominal pain, or they have blood in the stool, that is a red flag that patients should be seeing ASAP. We sometimes, because of the nature of our state that patients are rural, we might have the patients go locally, get labs, get a stool biofire, CDEF, and check whatever they can check locally, and start them on steroids and also antibiotics. And the reason we do that is because it might take a couple of days for patients sometimes to reach us. Some other things help, like cholestyramine or mesalamine, and cases that are refractory to prednisone or IV steroids, they will require some other drugs like infliximab or vedolizumab to be added, and that's usually you're looking at a severe colitis and the patient is in-house, and getting these medications and having their bowel movements count and daily assessments and whatnot. Next.
So I'm going to discuss the endocrine toxicities. So as Dr. Bustamante mentioned, the thyroid toxicity is one of the most common side effects of immunotherapy. Typically, we see a low TSH initially, so we obviously recommend checking the TSH before you start the therapy. Some patients are already on Synthroid before starting this treatment, so that's just something to keep in mind. Sometimes their dose may need adjusted ahead of starting treatment, but usually you'll see a low TSH first, so they develop hyperthyroidism. It's not very common to actually have to need to treat this hyperthyroidism. Most patients are asymptomatic. In the years that I've been treating this, I think I've had 1 patient that actually required treatment for hyperthyroidism, and eventually she also developed hypothyroidism. So just something to keep in mind. Typically 2 to 3 months later, the TSH normalizes, and then that's when you see the hypothyroidism develop. So this includes monitoring during the management is monitoring during hyperthyroidism, and then thyroid replacement hormone for whenever it develops. So monitoring throughout treatment. You may have to adjust this dose a little more frequently. We usually check it at least every 6 weeks whenever the patient's here for treatment, and then don't make dose adjustments until the patient has been on a dose for about 6 weeks per your standard management of hypothyroidism. You may also see hypophysitis or secondary adrenal insufficiency. The management is usually to hold the immunotherapy until the patient is stable on steroid replacement. This is something that the patient typically does need lifelong steroid replacement with. Most patients are started on one of the steroid treatments outpatient, and they receive a morning and an morning and an evening dose. And then you can resume the treatment once the patient stabilizes. Typically what you're going to see whenever this patient presents is with a low blood pressure and weight loss. So those are the things to be on the lookout for. You will have to also make sure they're not taking a lot of blood pressure medications. Frequently, these patients have other comorbid conditions that may impact this. So from our standpoint, if a patient's presenting with fatigue, it's important to check for cortisol and ACTH. If the patient's not on steroids, if they are on steroids, those levels won't be accurate. So we can go to the next slide. Patients can also develop type 1 diabetes. These are typically managed with standard diabetes medications. So we usually do involve either their PCP or endocrinology in this toxicity and in the management of the adrenal insufficiency or hypophysitis. Sometimes we do end up managing the hypothyroidism ourselves or send that to the PCP. But just for reference with the diabetes, we also have these patients on steroids at various points if they develop another toxicity or if they have if they're receiving chemo with their immunotherapy, just something to remind the patient that those steroids can increase their blood sugar and that they need to keep an eye out for that. Next slide, please. So liver toxicities, patients may develop hepatitis, noted by elevation of LFTs. The workup should include looking for other causes, including viral causes, and a review of the medication list for hepatotoxic agents. It's important to ask your patients about alcohol use or abuse. They don't often think about this, and also to ask them if they're taking over-the-counter cold medications or Tylenol. They don't always tell us about these things, and those can impact those LFTs. It's reasonable to complete imaging and possibly biopsy prior to assuming that it's related to immunotherapy, because some patients may actually be experiencing disease progression rather than immunotherapy related toxicity. So the standard management of this is with steroids, 1 milligram per kilogram per day of prednisone, along with the slow taper of that. And some patients may require second-line therapy with mycophenolate or Cellcept if the LFTs don't improve on steroids. And it's important to note that we don't use infliximab in this management, but this would be done primarily by the oncology team in consultation with GI. And usually if the patient's requiring a second-line therapy, they're being monitored very closely, either very closely outpatient or they're inpatient. Next slide, please. So for skin toxicities, patients can also develop pruritus, basically anything that ends in itis, like Dr. Bustamante said. So you can develop this with or without rash. This can be managed with oral antihistamines and topical steroids to localized areas. Usually we do not need to hold the immunotherapy for this toxicity unless the patient develops severe symptoms. Consider a dermatology consult if severe symptoms do develop. And sometimes if you get to a grade 3 toxicity, the patient may require the oral steroids. In general, patients do frequently report itching with or without rash. And they blame it on a lot of other things. You also want to make sure you discuss with them, did they change anything recently? Detergents, just the standard things that you would do for a rash before you blame it on the immunotherapy. Next slide, please. So these were just some clinical pearls that Dr. Bustamante and I had discussed. Patients are commonly given a wallet card with the name of the immunotherapy and the prescribing physician to present at an ED or urgent care visit. So providers are aware of this patient's treatment. I know that we do that here, and I know it's recommended by the NCCN guidelines for immunotherapy. So we definitely encourage that at any of our other sites. If there are concerns regarding potential side effects from immunotherapy, you should reach out to the oncology team, and then other specialties may be involved based on the specific toxicity. Patients may require an extended steroid taper and may experience rebound during or after that steroid taper. So sometimes you may end up starting them back on it if they develop the toxicity again as you're tapering them off or after the taper's completed. And if the patient has moved to less frequent follow-ups with oncology, it's reasonable at primary care visits to consider checking TSH and LFTs just to watch for this, because these toxicities can develop at any point after receiving immunotherapy. Next slide. It's just one of our references. I think that finishes that slide deck, Andy.
Yeah, thank you very much. At this time, we are going to take questions for our presenters. And Mary Ellen, if you can do that for just a second, I'm going to attempt to fix my PowerPoint settings so I can get it into present mode.
Okay, thank you.
Thank you.
So as Andy stated earlier, if you have a question, please feel free to use the raise hand function in the reactions, or you can type your question into the chat. So we'll wait to see if anyone has any questions.
Amy, it looked like your hand was up.
Yes, this is a quick question. It's not specific to a toxicity, but I guess it could be. It's my understanding we have lots of people in our state who suffer from arthritis. And I'm wondering about people who have potentially had a history with different biologics, and how does that impact the utilization of immunotherapy and treatment for cancer, or potential side effects down the road for them?
So when you say that they're using biologics, you mean for maybe an autoimmune condition?
Yeah, like a rheumatoid arthritis, psoriatic, something like that, or those types of related.
Right. So those are usually very challenging cases, because when you have, for example, psoriasis, or you have rheumatoid arthritis or lupus, we kind of shy away from using immune checkpoint inhibitors or immunotherapy altogether. We tend to start like with either chemotherapy alone, or if there is a target, then you kind of hit the jackpot, because then you can give a pill that is not immune mediated, so that you can have the chances of having a flare. But around 50% of patients with an underlying disease that is autoimmune will have a flare. Now, if the patient has been in remission for a long time from their autoimmune process, I might check rheumatoid factor, anti-CCP, and all those things, and kind of have a very long discussion and candid discussion with the patient, and kind of come to an agreement. Hey, I mean, if you're moving forward with this, we have a 50% chance of having a flare, and then of course we'll have to stop it, and hopefully you won't get such a severe side effect that you will end up in the hospital. But sometimes we're desperate, we're in second, third line, it's a younger patient that has still a lot of good performance status to tolerate therapy, and we don't have much more of any option, and then we decide to move forward. And some patients, they do get a response in many cases, and then you have to stop it, and that response might give them a few extra months of cancer control. But like I said, it's generally a very challenging situation, and we tend to avoid it. We have had cases, for example, that develop colitis, or they have Crohn's. So sometimes we do have maybe a discussion of doing vedolizumab, which might be just targeted to the colon, and then you might keep the immunotherapy effect. But again, it's very tricky, and you will be very scared to give it, because you can exacerbate a nasty colitis, and they might end up perforated. So, but at the end of the day, it's cancer, and that's going to kill them as well. So when you are desperate, you might move forward and do it. But in general, if the patients are on biologicals, we tend to avoid it, because their disease might be active, and you might ablate the effect of the immune checkpoint inhibitor. So
Thank you.
But I know we also educate our patients, even with osteoarthritis, that may worsen as well. Just putting that out there, that those ones typically aren't as bad, but we do educate them too.
Do we have any other questions before we head into our case discussion?
Andy, I do have a question for our presenters. When you were discussing liver toxicities and the need for assessing alcohol use, I did have a question with medical cannabis now being allowable in West Virginia and some of those coming in an oral administration route. Is there any contraindication or need for assessing the use of cannabis?
So I usually try to have them avoid at the very beginning to use cannabis. And it's not so much because there is let's say, interaction between the immunotherapy that will give a side effect, but it's because there's data, mostly retrospective, that says that shows that the immunotherapy effect is cut in half when you start cannabis. And the reason is because there appears to be an anti-inflammatory effect of the cannabis, and that will decrease the efficacy of the immunotherapy. So I try to handle the symptoms of the patients with other type of drugs as long as they're getting immunotherapy. Typically, at least in what I see, which is lung cancer, immunotherapy is frontline. So at the very beginning, that's why I'm saying I have them hold off on any medical cannabis type of therapy. And when they start progressing and having more symptoms and the immunotherapy is not working anymore, I'm like, you know what? We give it a try with immunotherapy, didn't work, or you progress to it and we need to change. I think if you still have symptoms and you still have the other medications are not working, I think it's reasonable to consider cannabis, but not necessarily from a side effect perspective, but more so for a decrease on efficacy perspective that it worries me. And the efficacy from this very beginning is not. So the response rate, which means shrinkage of the tumor and control of the tumor, it usually can range from 20 to 40% of the patients. So it's already not super high. If it works, it tends to work for many, many months. But you really decrease your chances from maybe from 20 to 10% and from 40 to 20%. So you really want to get the best response at the very beginning, because half of the patients won't make it to second line. So that's why I try to really avoid cannabis if you're using immunotherapy in the first line setting.
Thank you.
Okay, in the interest of time, we're going to go ahead and move into our case discussions. Before we do, as a reminder, those of you that are on the call, you can submit a case at any time for echo consideration. It doesn't even necessarily need to be based specifically on the didactic of the day. Perhaps you've had a patient come into clinic that just had some long-term side effects from cancer treatments, and you've tried everything that you know, and you would like to hear other people's thoughts on it. We actually have our training on Thursday, Mary Ellen and I, of our new case presentation form. So stay tuned for that. We'll send it out via email. But we would love to have questions that you have from your own clinical work that our experts can weigh in on. So just consider that, put that in the back of your mind as you are going through your daily practice with your patients. And I think that I have fixed the PowerPoint. Okay, yay, it worked. Okay, so this is our first case discussion. Adrienne or Dr. Bustamante, which one is this for you?
This one's mine, so I can do this one.
Okay, take it away.
So this was a 64-year-old female that was initially found to have a left frontal lobe mass after developing right leg weakness and word finding difficulty in August of 2017. She had an MRI done locally, or I believe she had started with the CT locally at her hospital that showed concerning findings, and she was directly admitted to Ruby. MRI showed multiple lesions, and the CT scan showed a left upper lobe subpleural nodule with mediastinal lymphadenopathy and a suspected adrenal nodule. So she underwent biopsy from the lung mass that was consistent with a poorly differentiated adenocarcinoma. And for these patients, we typically treat their brain first and separately from their body for patients that don't have a targetable mutation. So she underwent gamma knife to 11 lesions and was referred to medical oncology for systemic therapy. We can go to the next slide. So she started treatment with combined chemoimmunotherapy using carboplatin, Alimta, and Keytruda in September of 2017. This is a standard regimen for patients that either have a high disease burden or who may have a lower PD-L1. The initial restaging scans for this patient in November of 2017 showed a significant response to therapy. Actually, all of her disease had resolved. So she was transitioned to single agent immunotherapy in late November 2017. We can go to the next slide. And then in April of 2019, she developed an elevated creatinine, which was initially thought to be related to contrast dye with her restaging imaging. So we held her treatment that day and then repeated it. The creatinine, so we gave her IV hydration and then checked it the following week. Some of these patients you monitor even more closely than that. And then she ended up being admitted from our clinic with a creatinine of 3.78. So with an acute kidney injury, she underwent a biopsy of her right kidney that was consistent with nephritis, which is one of the toxicities that can develop with immunotherapy. She was evaluated by nephrology and they felt that that acute tubular interstitial nephritis was related to the immunotherapy. So she was started on the prednisone taper with 1 milligram per kilogram per day initially after receiving IV steroids inpatient. And she completed that taper in July of 2019. Given the severity of the toxicity, that it was a grade 3, her immunotherapy treatment has not been restarted. And she's been monitored with follow-up imaging since that time. And she remained disease-free on her most recent scan from this month. So that's my case. We can move on to Dr. Bustamante's.
So I brought a case of it's a 65-year-old female, also with metastatic non-small cell lung cancer that basically had spread to the left side of her pleural space with a malignant pleural effusion. So this patient had a high PD-L1 and she was started on Keytruda, and she have a great response. In fact, it looked like a almost complete response, but 6 months down the road, she started developing shortness of breath, hypoxia, and there were many reasons that we were concerned that there could be several processes going on. One could be the cancer progressing, a pulmonary embolism, also a pleural effusion, malignant pleural effusion, and also a pneumonitis. So the differential was kind of broad. So when we had a CT chest done for her, she had a diffuse bilateral ground glass opacities, and that was going along more so with a pneumonitis process. She never had radiation to suspect radiation pneumonitis. And the other concern is maybe she could have COVID or some viral infection. But in reality, there was not so much of a positivity to any of those tests, which were also tested on her when she was in the inpatient side. So we decided to start with prednisone. She had actually a pretty good improvement within 24 hours. She felt better. So that kind of gave us a clue that it was immunotherapy related. And I do believe we treated her for different infections, bacterial type, and actually PCP as well, or PJP, because she did not want to undergo a bronchoscopy. So we did a lot of empirical treatment on her. And she got better with the prednisone, but she started having worsening of this process a few weeks after, and then we had to start a second agent, which was IVIG, and at some point we incorporated mycophenolate, and she did attain a little bit of an improvement, but generally what we see if they have a relapse of the pneumonitis after prednisone and they don't respond well to prednisone, it's going to be a very, very hard process process to control moving forward. We had to stop pembrolizumab, which is also Keytruda, and the patient remained on immunosuppression. And like I said, the infectious causes were ruled out, and she stayed on immunosuppression for a long time, maybe up to like 5 to 6 months, and then some other stuff happened. She got very sick from an infection, a gastrointestinal infection, and her cancer started progressing, and other therapies didn't work, and unfortunately she passed away. But this is just to illustrate how something that can pass by either a COPD exacerbation or a pneumonia, it actually is pneumonitis, and we have to be alert and do the rule out infections, do the imaging testing that we need to, and start therapy as soon as possible, and be very careful with the taper strategy, and because people can relapse, and when they relapse with the pneumonitis, it's very difficult to put it back in sort of a remission of that immune related process.
Thank you both so much. Does anyone have any questions about either of these cases, or perhaps about a case that you've seen on your end that is similar, or that you would like to have their thoughts on? Okay. We would love to have your questions. Oh, go ahead. I'm sorry, Mary Ellen, it looked like you were going to say something. Am I wrong?
Oh, no.
Okay, sorry. All right. So just so everybody knows what is happening next with Echo, share again, our next session is going to be, there we go, on February 28th, and this will focus on young colorectal cancer screening and diagnosis. Of course, this is timely because Colorectal Cancer Awareness Month is March 1st, so this leads directly into that. As I said before, Mary Ellen and myself will have our training on our Echo case form, so we will get that out to you in our follow-up email should you have cases that you would like our panel experts to weigh in on. You also will get a follow-up email from us that does a summary of today's session, as well as the link to potentially watch it on our YouTube page. And Mary Ellen has posted in the chat again how to sign up for CEU credits. So remember, if you've already done this, you don't have to do it again. But if you've never applied for credits through our Echo, if you click on that link and fill out the form, then Mary Ellen will take it from there and make sure that you receive your credits. Just as you all know, very well be patient with that process because sometimes it takes a little longer than we'd like it to. Our guest presenters, did you have anything else that you would like to share with our guests today? We really appreciate your time.
I would just say that don't be shy to reach out to us if you have any questions, or when you're treating a patient and you have a question about if this could be potentially a side effect, either notify us or send the patient right away for us to see, because sometimes things can be masked or look very, very benign, but it's just a matter of a few hours and they can deteriorate fast. And the other part is that if you feel that maybe you're dealing with something that looks infectious, but you're not sure if it's autoimmune, and some people are scared of giving steroids because it's immunotherapy, but short-term steroids shouldn't ablate the effect of immunotherapy. So if you're not sure and you feel that that could give give them time to get to the oncologist. I would say that is okay, but as long as you have the patient, make sure that the patient follows up with oncology so that we can kind of tease out exactly what's going on.
And I was just going to say, I see that several of our APPs from regional sites are on. So I would just suggest downloading and using that NCCN guideline for immunotherapy related toxicities when you're seeing these patients to make sure that you're covering all of your bases if the patient reports side effects. That guideline is very thorough and gives specific guidance on what you should check and what labs and tests.
Thank you both. I think the overreaching theme from these two is please reach out. If you have questions, don't hesitate. They want to help you. They want to help their patients. And it also sounded like in my listening, this is something that can happen very quickly. So don't hesitate. I think a lot of times we think, oh, everybody is so busy. And yes, that is true. Everybody is so busy, but part of the reason we're busy is because we really care about our patients and their health and people. So don't hesitate to reach out, not just to these two experts, but to your patients, oncologists in their realm. They're here for the collective treatment of their patients. So we really appreciate the two of you giving your time today and your expertise. And I think that these two might be back in April for lung cancer biomarkers. So if you liked them this time, you definitely should come back in April and see them work their magic in that realm too. So thanks, everybody. And I hope you have a really great day. Take care.
Thank you all.